Welcome, everyone, to the iGIE podcast. iGIE is a newly launched journal as of December 16th, 2022. It was our premier issue. iGIE is part of the GIE, Elsevier, and ASGE family. Our editor-in-chief is Dr. Christopher Thompson. My name is Neil Sharma. I'm the chair of the editorial board, and I'm joined today by two of our authors for one of the journal articles that we're going to cover here over a few minutes in our premier issue. Please introduce yourselves.
Hi, everyone. This is Abhishek Agnihotri. I'm a gastroenterologist and advanced endoscopist at Bay Health Medical Center in Delaware. My focus is on endoscopic ultrasound, interventional EUS, and third space endoscopy.
Hello, everyone. My name is Alexander Schlachterman. I'm a therapeutic endoscopist at Thomas Jefferson University and the director of the third space endoscopy program. The focus of my practice, although I love ERCP and EUS, is focused on ESD, endoscopic submucosal dissection, and per-oral endoscopic myotomy. Thank you.
Excellent. Well, welcome, Alex. Abhishek, I'm going to ask you to talk a little bit about your article. Can you give us the article's title?
Yes, the title of our article is "A Novel Through-the-Scope Steerable Grasper for Dynamic Traction Reduces Dissection Time and Technical Demand in ESD in Novice Endoscopists Compared to Clip-and-Line Traction Method, an ex vivo randomized study."
Okay, that's a mouthful. So tell me a little bit about what this article is all about. How is it designed and kind of what's the purpose of it?
Sure. So the aim of our study was to assess the efficacy and also technical demand of using a novel steerable grasper arm for dynamic traction compared to clip and line traction method. So it's an ex vivo study. We had 10 participants. So these were novice endoscopists with no prior experience in ESD. And these were randomized into two groups. Group one was performed ESD using the steerable grasper arm first, followed by the clip and line traction method. And group two performed the ESD first with clip and line traction method, followed by steerable grasper arm. We chose novice endoscopists because we did not want to introduce any bias from prior ESD experience. So a porcine ex vivo model was used and 25 millimeter lesions were marked for ESD. Every participant underwent a 30-minute proctoring session where they were introduced to the devices and they were taught the basic steps of ESD. But during the randomization, when they were performing the actual ESD for the study, no external help was allowed to the participant. So coming to the results, we found our primary outcome, the mean dissection time, was significantly shorter with using the steerable grasper arm. It was mean was 5 minutes compared to 20 minutes with the clip and line traction method, irrespective of the order of randomization. Yeah, coming to our secondary outcomes of adverse events, there were 4 instances of muscle injury in the clip and line traction method compared to none in the steerable grasper arm method. There was 1 instance of perforation in the clip and line traction method compared to none in the steerable grasper arm method, not reaching statistical significance. And we used the NASA task load index, which has also been used in other endoscopic studies to assess the technical workload. And across all domains, the scores were lower in the steerable grasper arm method compared to clip and line method. And this was statistically significant across the groups. So in summary, steerable grasper arm, which is a novel traction device that provides dynamic traction, reduces ESD dissection time compared to clip and line traction method in novice endoscopists. And use of steerable grasper arm showed a trend towards reduced procedural adverse events. And it also led to a significantly reduced technical demand on the endoscopist and may be a promising tool during the early learning curve phase of ESD training. Thank you.
Excellent summary. I appreciate that. For anyone who wants to see the article, again, this is an open access journal, which is the nice thing. So anyone has the ability to access your work and review the article in depth. I'll ask a little bit of just commentary from both of you relevant to what you think are maybe 3 or 2 take-home messages that you got from conducting the research.
So maybe I'll chime in first. Abhishek, that was a wonderful description of the study. I'd have to say that, you know, the major take home from a study such as this is that we're looking many times to assess safety. Secondary would be efficacy, and then three, is it potentially a technique or device that could be utilized for curative resection? And I think in a positive fashion, we were able to show that with this study utilizing this particular traction technique. So I was very pleased to say that this was a study that is applicable for other folks learning or interested in ESD, covering that again, safety, efficacy, and the ability for curative resection.
Excellent.
Yeah, I completely agree with Dr. Schlachterman. I think the three takeaways. I won't repeat our conclusions again, but things that I was pleasantly surprised to find was in novice endoscopists, which includes second to fourth year GI fellows. So these are fellows who have minimal EMR experience and certainly no ESD experience. How much difference in dissection times the device made, and also the difference in adverse events. So I think earlier on in the career, when the focus is more on safety, when we are starting to learn to do ESDs, this device can help reduce the risk of adverse events, and also increase the dissection time, especially earlier on in the career, when we know that the dissection times are usually the longest. And I think the most important point is dynamic traction really makes a significant difference. And this has been shown in other studies comparing robotic ESD platforms. However, they are much more cumbersome. So compared to multiple other traction methods, the ability to have dynamic traction really does speed up things.
Yeah, that's great. So, you make a couple of really key points, and this is what iGIE is supposed to be all about. It's about taking technologies and finding the right way to apply them, getting a better understanding of where these technologies are, maybe where they need to go, how they can help us get better outcomes. It's also just about insights and innovations. And so, when you designed this trial, I thought it was really interesting. This is a commercially available device. Is that correct? And so you
Correct.
applied it to people who have no experience in ESD. And the biggest thing that I find with ESD and just teaching at conferences or talking about its utilization in real time, meaning for service of patients, is the reproducibility of ESD, getting those skill sets, right? So talk to me a little bit about how you created this design, you put it in the hands of novice endoscopists, and this device is now available. So where will this go from here?
Right. So maybe I'll take this question on. So many times we get an opportunity where we're doing pretty well with our ESD, and you wonder, shall I bring in a new device and really see, is this going to help me? Is this going to slow me down? So at Jefferson, one of my goals at the third space endoscopy program is to look for safe and efficient ways to do ESD. Fatigue is a big component of ESD, so we want to be as efficient as possible. Obviously, you don't know which device is going to work in which fashion, so we have to be mindful of when and how we're going to do these things. So doing a study such as this, where we get a device that's available on the market that has promise, and really put it to the test and say, how can we evaluate this device to see if it's going to be beneficial in the long run? You need to take the factor out of the equation, such as the endoscopist with years of experience, and really say it's the device that's either helpful in the setting for lots of different people, or is it really just the endoscopist? So as we discussed this and we thought about the study itself, we were looking for ways, and that's why we came up with third and fourth year general GI fellows who hadn't done ESD before, because it really eliminates that as a question. And then we're focused on two different specific traction techniques: the clip line, which has been around for a while, and then this particular device itself, this traction device. So the study came about really of trying to isolate the factor to evaluate safety, efficacy, and ability for curative resection.
Yeah, I love that design element of taking the variable of the operator out, which is such a heavy component of a lot of ESD studies is experience, right? And you really point that out. So now with the design and this device, do you think it would affect the way that you would teach others ESD? I mean, would you typically we have, I train in Japan. I know you spend time in Japan. This mentorship that is long, laborious, but very thoughtfully designed. But now you have these disruptors. So how do these disruptors factor into that?
Yeah, so it's a good question. It's hard to say with a new device where is the best place to apply and whether to use a cap. Distal cap attachments play a huge role, and I think in traditional ESD we all use that, right? The cap really is helpful for traction in itself. In a device such as this steerable grasping arm, we have to say, okay, is visibility efficient or um, sufficient, or do we need to remove the cap? So I think location, whether or not to use other devices in combination with this traction technique, still need to be worked out. So, it's hard to say when and how each thing is going to be utilized. And with experience, we're going to be able to apply that. I could say for this particular device, when I'm using it in folks, the stomach is really a good location. Rectosigmoid lesions are a good location. There are some limitations in other spots just because of the distance that we're working, which is one of the drawbacks. But I think we're getting that with different types of experience, and so we're looking forward to working and adding that data as we hear more and more. So I think I've answered your question, but sometimes I tend to ramble. I'll tell you that there's not one setting for a particular device, and I think we need to apply and consider multiple settings where we can use traction and how we can use them.
And that's great. And just to add, from an early learner standpoint, last year as I was getting the basics of ESD, going through my training, I think the trainee population is a good population where these devices can be very helpful, because later on in your career, when you have that experience, then you can safely perform ESD. You can be efficient at performing ESD with multiple different traction devices. But earlier on in the career, especially when you're learning, I personally feel that's when the effect of these devices is much more in your ESD training.
Perfect. All right, last question. So we have a novel device. The two of you have designed a really thoughtful study in an ex vivo model where you certainly have demonstrated that dynamic traction has a big value add. It's different than other methods where we try to essentially jerry rig our own traction. Clip and line is a great example, but we use a variety of things like rubber bands and so on. So where do you think this will go, having a valuable device like this in terms of influencing traction device development in the future? Your study in particular, but opening doors for where we can go with ESD and or robotics.
So look, I think, having the ability for traction in ESD is invaluable. I joke with the surgeons, they get their medical student to hold traction. We don't have that ability in our ESD. So we've got to think of creative ways, whether we're using dental floss or clip line as one, or a second device through a 2T or a double channel scope is another. There are side channels that are being added and offered with different, traction techniques, overstitch and doing the ability to stitch to the opposite wall and drop the anchor. Lots of really creative methods. I've heard of snare and, pulling and pushing and holding the lesion as you dissect. I think people are getting creative. And as we're able to apply this, depending on the location we are, whether it be the esophagus, stomach, colon, or rectum, we have to consider what's the best traction technique for that location. And so I don't think it's going to be one, but I do think that the better we get with different traction techniques and devices such as this steerable grasping arm or track motion, I think we're really going to see everything that we're looking for: the safety, the efficacy, moving forward. So I'm very hopeful in the growth of ESD and making this a procedure that we can apply throughout the country and the world, because we still have some time to catch up and need to catch up to our partners around the world. But I think there's innovation that can be really applied here.
Yeah, no, completely agree. Just to add to that, I think I'm excited about the various devices in development. We've seen some interesting case reports with other ex vivo models, in particular with dynamic traction. And I think using because the one of the limitations of using a double channel instrument is the device diameter. So the double channel gastroscope used for this study was 12.2 millimeters compared to regular gastroscope, which is just under 10 millimeters. And that can sometimes make it challenging to tunnel through and get under the lesion. And there's interesting concepts about using an additional side channel on a regular gastroscope. So I think that's an area ripe for innovation, where we can use a regular gastroscope or regular colonoscope, and then have a side channel to pass some other instruments to provide more dynamic traction. So I'm looking forward to more development on that front.
Excellent. Alex, Abhishek, thank you so much for sharing your time with us. It's really great example of how two experts can function as physician scientists and create an ex vivo model for a research study to understand these new devices. And I hope everyone gets a lot of value out of listening to the two of you and gets an opportunity to read your work. Thank you again. Happy holidays.
Thank you,
Thanks
Dr.
for
Sharma.
having me. Happy holidays.